G'day team, and welcome back to Overheard in the Emergency Room, the show where we uncover the two-tier blueprint for optimal health and well-being. As always, let's start with a story from the emergency room. I had a 42-year-old male who came in with pain in his groin. He had an abscess that needed incision and drainage and antibiotics. He looks kind of anxious and not particularly unwell. He's overweight, and given he had a nasty looking infection in the groin, I wanted to make sure that he wasn't actually hiding a really scary sepsis under his well-appearing veneer. Now, the scariest infection here is something called Fournier gangrene. Please do not Google it. I got his labs. His blood sugar was 440. For those whose mouths are not on the floor right now, the normal range, depending on the lab, is anywhere from 60 to 100. His HbA1c, which is a measure of his long-term glucose control, is 10.4%. Now, this man does not carry a diagnosis of diabetes, but this was a fasted sample, so he definitely does have the diagnosis now. He is a 42-year-old father of 3. He works on the road in sales and sustains himself on meals on the run with fast and convenient food as the go-to option. Type 2 diabetes and metabolic disease rarely bring people to the emergency department on their own, but their complications absolutely do. This man's abscess is one such complication. Fortunately, it's a very visible and painful complication of his tissues being saturated in sugar. Other complications are indolent and take years to develop: peripheral vascular disease, neuropathy, chronic kidney disease, vision loss. These are largely silent until they are not, and quality of life goes down. And medications for management go up. And when you zoom out, these cases aren't random. They're often predictable. They are the end of a slow process that's been unfolding for years. Today, we're talking about metabolic health, specifically metabolic syndrome and type 2 diabetes. Metabolic health has unfortunately become a buzzword on social media, and I don't want you to get caught up in the hype or by the grift of some folks. There is not going to be any diet camps or magic cures, but we will present our evidence in our typical two-tier blueprint style. So let's answer. What is metabolic syndrome and diabetes? Why are they so common? And what actually works to help fix them? Let's get into it. And before you do, please hit the like and subscribe bell so you can get more of our content. Let's start with metabolic health. Metabolic health is about how well your body handles energy, substrates like glucose and fat, and then how those interact with your blood pressure and your lipids. When these systems are coordinated, things run smoothly. When they drift, risk accumulates. Metabolic syndrome isn't one disease. It's best thought of as a cluster of conditions that tend to travel together. Central adiposity, so how much weight you're carrying around your midsection. Elevated blood pressure. Abnormal lipids, typically high triglycerides, low HDL, and typically elevated LDL. Insulin resistance or impaired glucose regulation, which can be determined by fasting insulin, fasting glucose, HbA1c, or an oral glucose tolerance test. Different organizations define metabolic syndrome differently. Now, for our purposes, the exact cutoffs matter less than the pattern. There's a lot of overlap between diabetes and metabolic syndrome, but I think that many people will make the mistake that you need to have metabolic syndrome in order to have diabetes. The reality is that you do not, and that a lot of these conditions are genetically determined and are activated by exposure to certain environmental cues, of which there are many in modern society. Metabolic syndrome is best thought of as a warning label, and it tells us that risk is building. In type 2 diabetes, the patient cannot effectively clear glucose from the blood. It builds from long-standing insulin resistance. What is that, I hear you say? Well, the primary organs in the body that are responsible for disposing of glucose are the muscles, the liver, and fat. They all have insulin receptors. These are basically locks on the surface of cells that open a gate to allow glucose to enter the cell. When it is bound to the key, insulin, which is circulating in the blood, opens this gate. We can talk more specifically about mechanisms later, but essentially, when glucose storage within these cells is already maxed out, insulin receptors are less likely to be translated to the surface of the cells, and therefore, no more glucose can get into the cells. Sugar will continue to circulate in the blood, leading to high blood sugar. Over time, there is increasing strain on pancreatic beta cells, which are the cells that are responsible for producing and secreting insulin. And eventually, they're no longer able to produce insulin. This is a late development in folks who have type 2 diabetes, and they often need to be put on insulin injections to manage their blood sugar. So these disease entities are not separate silos. They are overlapping circles on the same map. But one can have diabetes without metabolic syndrome, which can be a little tough to get your head around. But it's really important to understand. So what about the numbers? In typical Overheard in the emergency room style, let's talk about my two countries, Australia and the US. In Australia, more than 1.3 million out of 25 million total population are living with diabetes. Most have type 2. And the annual cost? Over $9 billion. Depending on the definition used, around 1 in 3 Australian adults meets criteria for metabolic syndrome, often without even knowing. In the United States, the numbers are even larger. Over 38 million out of 330 million people are living with diabetes. More than 1 in 3 adults have prediabetes, a condition where your blood sugar is creeping up but not yet meeting the criteria for diabetes. The annual cost in the US exceeds $400 billion. Two different healthcare systems, very similar curves. That tells us that this isn't a failure of individual willpower. It's biology interacting with the environment, and you know that our environment makes it very challenging. There is a lifetime's worth of inexpensive, nutrient-devoid calories on every street corner convenience store. And this is where I think the social media wars are so unhelpful. The cause and pathophysiology of metabolic disease is complex. Many of these social media grifters will get so myopic and speak confidently about how X is the cause of metabolic health after telling a compelling story about how they overcome some dire medical problem. They will then proceed to sell you a supplement or a diet approach that is the only way to cure the root cause of metabolic dysfunction. All along the way, likely selling you some narrative that the so-called medical establishment has been lying to you just to keep you sick. This couldn't be farther from the truth. And I think we should spend some time talking about how metabolic syndrome and diabetes happens so that we can cut through this unhelpful noise to actually help people. All right, now that we've talked about how common this is, let's talk about how it actually happens. Because this is where a lot of online conversation goes completely off the rails. Metabolic syndrome and type 2 diabetes are not caused by one thing. Not carbs, not high fructose corn syrup alone, not insulin spikes, and certainly not seed oil. They're the result of multiple systems in a genetically vulnerable person slowly drifting out of sync. Here's a simple way to picture this. I want you to imagine your metabolism like a warehouse system. Your muscles, liver, and fat tissue are the shelves in the warehouse. Glucose and fat are the energy packages. Insulin is the barcode scanner that lets you put the packages on the shelves. When the warehouses have space, packages move in easily. But when the warehouses are already full, things change. Packages start backing up. The scanners stop working. Because we have all of these delicious, easy to eat foods on every corner, the deliveries keep arriving anyway. And that traffic jam, that's insulin resistance. So let's talk about how insulin resistance starts in 3 main places: skeletal muscle, the liver, and adipose tissue. As we said, these tissues are responsible for clearing glucose from the blood. Early on, insulin resistance doesn't mean no insulin. It means that insulin isn't working as well as it should. As a result, the pancreas responds by producing more insulin. That's why early metabolic disease often looks like normal glucose, but very high insulin. This is a key point that gets missed online. High insulin is often an early warning sign, long before diabetes is diagnosed. Let's talk about visceral fat and why location matters, because not all fat behaves the same way. Subcutaneous fat, the stuff under the skin, it's relatively passive. Visceral fat, on the other hand, the fat that's stored deep in the abdomen around the organs, is metabolically active. It actually releases pro-inflammatory cytokines, free fatty acids, and it creates chemical signals that interfere with insulin action. This can create chronic low-grade inflammation. This is probably what the social media influencers are talking about when they loudly exclaim that insulin is the cause of all of your problems. So there is a kernel of truth to that, but the reality is this is caused by the deposition of visceral fat. So that is what we should be trying to target. And that inflammation worsens insulin resistance, impairs blood vessel function, and disrupts lipid metabolism. This is why waist circumference is such a powerful predictor of risk, often more informative than weight or BMI alone. The liver plays a central role here. In insulin resistance, the liver becomes less responsive to insulin's signal to stop making glucose. It continues releasing glucose even when blood sugar is already high. At the same time, excess energy is stored in the liver as fat, what we now call fatty liver disease. A fatty, insulin-resistant liver produces excess glucose, and it pumps out triglyceride-rich particles and drives the classic lipid pattern of metabolic syndrome: low HDL, high triglycerides, and elevated LDL. This links metabolic syndrome directly to cardiovascular disease. Insulin resistance and visceral fat also affect blood pressure. The degree of chronic inflammation from visceral fat reduces nitric oxide availability and makes blood vessels stiffer, which leads to increased blood pressure. Adipose tissue also interacts with the renin-angiotensin system, a complex system that helps regulate blood pressure through hormones and involves the lungs and kidneys. It promotes sodium retention and vasoconstriction, which ends in higher blood pressure, less flexible blood vessels, and higher cardiovascular risk. For years, the pancreas compensates by pumping out more and more insulin to overcome the resistance. But the beta cells aren't infinite. Over time, beta cells become stressed. Their function declines and insulin production can no longer meet demand. Now, I know what you're saying. This sounds very buzzwordy. So here is what actually happens in 5 deeper steps. Number 1, chronic hyperstimulation and stunning due to high demand results in desensitization. Number 2, glucolipotoxicity. As compensation fails, blood glucose rises and fatty acids remain high, which creates a toxic environment for beta cells. Saturated fats and high glucose compel mitochondria to overwork and create reactive oxygen species. The beta cells are uniquely vulnerable to reactive oxygen species, as they have low levels of antioxidant enzymes, which results in damage to organelles, lipids, and the DNA. One of the protein-creating organelles in the beta cells, the endoplasmic reticulum, can get overwhelmed with the demand for insulin production, and proinsulin can accumulate and trigger programmed cell death, something called apoptosis. Number 4, some recent studies suggest that beta cells don't just die, but rather lose their identity. They lose their ability to produce insulin and revert to more primitive, inactive, or undifferentiated states. 5, destruction or apoptosis and necrosis. There ultimately comes a point when the beta cells reach a point of no return. The damaged cells will undergo apoptosis and programmed cell death we talked about earlier. Let's spare a moment for those poor little beta cells. When this has happened, glucose levels rise dramatically, and type 2 diabetes becomes obvious. This is why many people with long-standing type 2 diabetes eventually need exogenous insulin. Not because insulin is bad, but because the pancreas is exhausted. We've talked a lot about how the environment patients interact with causes the canon of metabolic disease. It is the case that our genetics load that cannon, and that the environment lights the fuse to fire it. There are hundreds of genetic variations associated with diabetes risk, but genes alone don't explain what we are seeing. What matters is the gene-environment interaction. So first, do you have the genetic susceptibility? Then how does your environment activate those genes? This can be through diet quality, physical activity levels, sleep, stress, early life exposures. This explains why diabetes clusters in families, risk changes across generations, and why prevention works best early in life. So when someone confidently tells you metabolic disease is caused by this one thing, that's your cue to be skeptical. Metabolic syndrome and type 2 diabetes emerge from energy overload, insulin resistance, high levels of visceral fat, chronic inflammation, genetic susceptibility, and an environment that makes unhealthy choices frictionless. All right, Dr. Coyce, tell me some good news. This process is slow and the result, at least in part, of our environment. So it's modifiable, which brings us to treatment and how we can actually intervene at different points along this pathway. And this sets us up perfectly for our next segment. So before we get into the evidence-heavy lifestyle discussion, which forms the basis of our Tier 1 interventions for metabolic disease, we need to zoom out and talk about the treatment strategy. One of the biggest mistakes that people make is treating metabolic disease like a single target problem. When we treat metabolic syndrome and type 2 diabetes, we're not just chasing blood sugar. We're trying to improve insulin sensitivity, reduce visceral fat, lower blood pressure, improve lipid profiles, all the while preventing cardiovascular, kidney, nerve, and eye disease. This means treatment has to be multi-layered. Lifestyle is the foundation, not an optional extra. And every major guideline agrees on this. And yes, including the American and Australian Diabetes Associations, organizations that are often maligned by the snake oil salesmen online. Lifestyle intervention isn't what you try before medications. It's the base layer that everything else sits on. And that includes nutrition, physical activity, weight management, sleep, and behavioral support. Even modest weight loss, in the range of 5 to 7% of body weight, can make massive improvements on your HbA1c, your blood pressure, and your lipids. Greater weight loss, 10% or more, can be disease modifying and in some people lead to diabetes remission. But lifestyle isn't just about weight, because improving your diet and moving more will also improve your insulin sensitivity even when weight loss is modest. Medications, they should be seen as tools, not failures. So when you've put in place some lifestyle modifications, it just may not be enough. And this is where medications come in. Medications are not a sign that lifestyle didn't work. They're simple tools that target parts of the pathophysiology we just discussed. Some help reduce hepatic glucose output, some improve insulin sensitivity, some increase insulin secretion, some slow gastric emptying or reduce appetite. Some of those increase glucose excretion through the kidneys. The newer agents, particularly GLP-1 receptor agonists and dual incretin therapies, have been shown to promote meaningful weight loss, improve cardiovascular outcomes, and reduce kidney disease progression. Importantly, guidelines now recommend choosing medications that help with weight and cardiometabolic risk, not just glucose numbers. Metabolic syndrome doesn't get one pill. You treat blood pressure with antihypertensives, lipids with statins or other lipid-lowering therapies, and obesity with lifestyle, pharmacotherapy, and/or surgery. This is why a comprehensive approach matters so much. Treating only one component leaves the others quietly progressing. Now, metabolic surgery deserves a brief mention here. For selected patients, it can produce large, sustained weight loss and rapidly improve insulin sensitivity. It's shown high rates of diabetes remission. And it works not just by restriction, but through hormonal and metabolic changes. Now, it's not for everyone, but it reminds us of something important. When you dramatically reduce energy overload, metabolic disease can be reversed. All right, let's get into the meat of this, the evidence. Let's start by talking about how we approach the evidence. If you've spent any time online, you'll quickly notice that people tend to live in very specific diet camps. Keto, low fat, vegan, carnivore, Mediterranean, intermittent fasting. And everyone sounds very confident that they've found the answer. For this episode, we deliberately didn't start with a diet ideology. We started with a search strategy. Specifically, we focused on recent systematic reviews and meta-analyses because these papers already pool multiple randomized control trials into specific unified data sets. That helps reduce the noise you get from single studies and gives a clearer sense of what actually happens on average when people change how they eat. Before we looked at any results, we also decided on the outcomes that we really cared about. So we weren't tempted to cherry pick wins for any one approach. These outcomes were HbA1c, insulin resistance, which is usually measured as HOMA-IR in a lot of these studies, waist circumference, body weight, blood pressure, and LDL cholesterol. Now, these aren't abstract markers. These are markers that predict heart attacks, strokes, kidney disease, amputations, the things that eventually bring people to the emergency department. We also ordered dietary approaches from the ones that have the most consistent evidence to the most controversial, not by how loud the online debate is. So first category, let's talk about dietary approaches for type 2 diabetes. Starting off with broad dietary pattern comparisons. The best place to start is a network meta-analysis that compared multiple dietary patterns head-to-head in people with type 2 diabetes. This analysis included 42 randomized trials over 4,800 participants with at least 6 months of follow-up. What's important here is not which diet won, but what the overall pattern showed. Across Mediterranean diets, low carbohydrate diets, low fat diets, low glycemic index diets, and ketogenic diets, many approaches lowered HbA1c compared with controlled diets. Several also led to weight loss, but no single diet dominated across all outcomes. The quiet takeaway is this: there is more than one effective dietary path for improving glycemic control in type 2 diabetes, and adherence and sustainability probably explain a lot of the differences we see, particularly when calories are controlled. Next up, Mediterranean and plant-forward dietary patterns. A large systematic review and meta-analysis looked at plant-based dietary patterns and found that higher adherence was associated with a lower risk of developing type 2 diabetes, cardiovascular disease, and all-cause mortality. Importantly, the benefit was strongest for healthful plant-based diets, not just diets that technically avoid animal products. Highly processed plant foods did not confer the same protection. Across studies, these patterns were associated with lower diabetes risk, modest weight reduction, and improvements in LDL cholesterol. And mechanistically, this makes sense. With plant-forward diets, you have a higher fiber intake, lower energy density of that food, and therefore can improve insulin sensitivity. Next dietary pattern, low glycemic index and glycemic load diets. A systematic review and meta-analysis of randomized control trials examined low glycemic index foods and low glycemic load diets in people with diabetes. These diets produced small but statistically significant reductions in HbA1c. They also showed improvements in fasting glucose and had variable effects on LDL cholesterol. Clinically, this suggests that carbohydrate quality may matter just as much as carbohydrate quantity, which is a useful message for patients who find strict carbohydrate elimination unrealistic and unwanted. Intermittent fasting, which is a pretty popular dietary pattern online. Intermittent fasting gets really a lot of attention, so it's worth grounding it in evidence. A 2024 meta-analysis examined intermittent fasting interventions in adults with pre-diabetes and type 2 diabetes. So what improved? First off, body weight. It improved by roughly 4 to 5 kilograms. HbA1c improved by about 0.8%, but what did not consistently improve? LDL cholesterol and blood pressure. So intermittent fasting can work for some people, but it's not metabolically magical. Adherence, hypoglycemia risk, eating disorder history, and compatibility with shift work all matter. Ketogenic and very low carbohydrate diets. A meta-analysis of randomized control trials looked specifically at ketogenic diets in overweight patients with type 2 diabetes. These diet patterns were associated with reductions in HbA1c, weight loss, and had mixed lipid effects, including variable LDL responses. And this is where the controversy often lives. Ketogenic diets can be effective for glycemic control in selected individuals, but the long-term cardiovascular effects and sustainability remain open questions, in part because oftentimes ketogenic diets avoid fiber-rich foods in preference for more saturated fat-laden animal foods. We also looked at this through a food exposure lens, ultra-processed foods and red meat in particular. Some of the strongest signals don't come from named diets at all. A meta-analysis of longitudinal studies found that higher consumption of ultra-processed foods was associated with a dose-dependent increase in type 2 diabetes risk. Another systematic review and meta-analysis showed that higher intake of processed red meat, and to a lesser extent unprocessed red meat, was associated with increased diabetes risk. These two studies don't prescribe to a specific diet, they describe risk gradients that help explain population level trends. Next up, dietary approaches for metabolic syndrome. Now with metabolic disease, we're looking at the same outcomes, just framed around waist circumference, blood pressure, lipids, and insulin resistance because it's a cluster of diseases. So first up, the DASH diet. The DASH diet has some of the most consistent evidence in metabolic syndrome. A systematic review and meta-analysis compared DASH diet with other dietary approaches in people with metabolic syndrome, and they found improvements in blood pressure, waist circumference, and LDL cholesterol. A second meta-analysis confirmed favorable effects of DASH across metabolic risk factors in chronic disease populations. And this matters because metabolic syndrome is fundamentally a cardiovascular risk cluster, and DASH targets that cluster directly. The Mediterranean diet. A meta-analysis of controlled trials found that the Mediterranean diet improved waist circumference, insulin resistance, and lipid profiles in adults with metabolic risk. So again, this supports pattern-based, sustainable dietary approaches rather than short-term programs. Let's talk about diet quality, in particular, legumes. Higher legume consumption was associated with a lower prevalence of metabolic syndrome in observational studies. Another meta-analysis showed that higher diet quality scores were associated with lower odds of obesity and metabolic syndrome in children and adults. A reminder that metabolic risk begins early. And let's look specifically at intermittent fasting versus continuous calorie restriction. A meta-analysis compared intermittent fasting with continuous energy restriction in patients with type 2 diabetes and metabolic syndrome. They found no clear superiority of fasting when total calories were matched. So the translation here is that energy balance still matters. Structure can help adherence, but timing alone is not a cure. Ultra-processed food and metabolic health. A broader meta-analysis found that higher consumption of ultra-processed foods was associated with worse overall health outcomes, including metabolic risk, which is probably not going to surprise anyone. This provides a unifying signal across diabetes and metabolic syndrome. What about lifestyle and diabetes remission? Finally, a meta-analysis of lifestyle interventions for diabetes remission that included nearly 4,000 patients found higher remission rates, significant weight loss, and improved quality of life. Now, remission is most achievable early in the disease course, before prolonged beta cell failure, and it requires ongoing support. So how do we wrap all of this together? Across type 2 diabetes and metabolic syndrome, the pattern is clear. No single diet wins every outcome. Food quality, energy balance, and adherence to a dietary pattern dominate. Lifestyle interventions like diet and exercise work best when combined with dietary approaches. Earlier intervention produces larger and more durable effects. Metabolic health improves when we reduce visceral fat, improve insulin sensitivity, and make the healthy choice the easier choice, regardless of the diet label. All right, before we wrap this episode up, we need to spend a few minutes on medications. Not a deep dive, because that deserves its own episode, but enough to understand what these drugs are, how they work, and why so many people are suddenly talking about them. Because whether you love them, hate them, or feel unsure, millions of people are now taking these medications, and the decisions around them matter. Let's zoom out and start with the big picture. Modern diabetes and metabolic care revolve around three major medication classes, each targeting a different part of the physiology, which we discussed earlier. Metformin is often the first medication prescribed in type 2 diabetes. It reduces glucose production by the liver, improves insulin sensitivity at the tissues, does not cause weight gain, does not cause hypoglycemia. You can think of metformin as turning down the liver's glucose tap. It's inexpensive, well-studied, and has decades of safety data. It doesn't fix everything, but it's a solid foundation. SGLT2 inhibitors work in a completely different way. They prevent glucose reabsorption in the kidneys, and they cause excess glucose to be excreted in the urine. This leads to lower blood glucose, modest weight loss, and lower blood pressure. But importantly, and this is why clinicians love them, They also reduce heart failure hospitalizations and slow the progression of chronic kidney disease. These benefits extend beyond glucose control, which is why they're now used even in some patients without diabetes. GLP-1 receptor agonists are the class that everyone is talking about. They mimic a naturally occurring gut hormone that increases insulin secretion when glucose is high, suppresses glucagon, slows gastric emptying, and acts on the brain to reduce appetite and increase satiety. The result is lower blood glucose, significant weight loss, improvements in blood pressure, lipids, and inflammation. But until recently, the big question was this: do these drugs actually reduce hard outcomes, like heart attacks and strokes, especially in people without diabetes? Which brings us to the SELECT trial. This is a large trial that was published in the New England Journal of Medicine in 2023. Let's take a moment to walk through this in PICO style, because this is how we separate hype from evidence. So the SELECT trial enrolled 17,604 adults who were 45 years or older, had overweight or obesity, so typically their BMI greater than 27, had established cardiovascular disease, but did not have diabetes. And that last point is crucial. This was not a diabetes trial. Now, the intervention. Participants were randomized to semaglutide 2.4 milligrams once weekly that was injected subcutaneously, or placebo. They were followed for a mean of almost 40 months. Now, the comparison. Semaglutide versus placebo on top of standard cardiovascular care. The primary outcome was a composite of death from cardiovascular disease, non-fatal myocardial infarction, and non-fatal stroke. And the results were striking. A primary cardiovascular event occurred in 6.5% of the semaglutide group and 8% of the placebo group. That's a 20% relative risk reduction, and it was highly statistically significant. Semaglutide was also associated with approximately 9% mean body weight reduction, reduced waist circumference, lower blood pressure, and improvements in inflammatory markers. And this was all in people without diabetes. This trial really has changed how we think about obesity and metabolic disease. It showed that treating excess adiposity itself, not just glucose, can reduce cardiovascular events. And this tells us something important. These medications aren't just weight loss drugs. They're cardiometabolic therapies. But, and this is critical, they are medications with real side effects, contraindications, and monitoring requirements. Which brings us to a very uncomfortable but necessary conversation. These bespoke compounded GLP-1 and online clinics, because they're in such high demand, they sell online subscription that doesn't fully pass out the risk. Some providers are excellent, but some are not. Some red flags I would encourage you to include when you're thinking about using one of these services. Ask whether they have a proper medical intake. Do they give you a discussion of the contraindications? Do they titrate the medication? Do they talk about the specific risk to the gallbladder, pancreas, and other organs? And do they support you through the journey? Because these medications change physiology, and they deserve proper prescribing and monitoring that's integrated into a comprehensive program that includes lifestyle support. And this isn't about gatekeeping, it's about safety. We are absolutely going to dedicate a full future episode to these medications. When to start them, when not to start them, how to combine them with lifestyle interventions, and how to think about how long-term use can benefit you. But for now, the key takeaway is this. Medications can be incredibly powerful tools, but they work best when used thoughtfully, ethically, and on top of a solid metabolic foundation. And that foundation, as you've just heard in the previous segment, is lifestyle. Let's zoom out one last time and talk about prevention. Because when we talk about metabolic disease, prevention often gets framed as eat better, move more, and try harder. And that framing is not just unhelpful, it's wrong. Prevention isn't about moral virtue. It's about interrupting a predictable biological process early enough that it never reaches the emergency department. One of the most important ideas to understand is this. Prevention and treatment of metabolic disease live on the same spectrum. The same mechanisms that drive metabolic syndrome and type 2 diabetes, insulin resistance, visceral fat, inflammation, and dysregulated energy balance, are the exact same mechanisms we target when we intervene early. The genes won't change, but our environment can. Think about the cost and availability of healthful foods, wage growth, having to work multiple jobs, being time poor, and health education, including what's your access like to get a physician. So when we talk about prevention, we're really talking about early upstream treatment. So what does the evidence consistently show? If metabolic disease is multifactorial, do multifactorial prevention strategies work? And the answer is yes, consistently. Comprehensive prevention approaches that combine nutrition quality, not just calories, physical activity, weight management, sleep, stress reduction, and provide social and environmental support will improve waist circumference, blood pressure, lipids, insulin sensitivity, and overall metabolic risk. Not through magic, but through small, cumulative shifts that reduce energy overload and inflammation over time, because you're reducing your visceral fat. It is important to understand that prevention works best where people actually live. A paper from 2020 assessed a community-based lifestyle intervention delivered to African American women, a group with disproportionately high risk of metabolic syndrome, diabetes, and cardiovascular disease. The intervention wasn't delivered in a university lab. It wasn't delivered by a specialist physician, and it wasn't built around perfection. It was delivered in churches by minimally trained community health coaches, using culturally relevant adaptations over a realistic time frame. And the results were striking. The prevalence of metabolic syndrome dropped by about 25% relative to baseline. Waist circumference decreased, blood pressure improved, triglycerides fell, overall cardiovascular risk went down. And this wasn't achieved through extreme diets or elite fitness plans. It was achieved through reduced calorie intake, improved diet quality, reduced sodium and unhealthy fats, increased physical activity, with social accountability and support. This is prevention that actually scales and demonstrates why sensationalism on social media is so unhelpful, and highlights the importance of the need to fund research initiatives for things like this so that we can actually get some change where people live. One of the biggest failures in metabolic health is not a lack of knowledge, it's a lack of implementation. We already know that lifestyle change works, that early intervention works better, and that community-based programs can work just as well as clinic-based ones. What's often missing is access, cultural consistency or relevance, time, support, and environments that make healthy choices easier. This is why telling people to just be more disciplined is such a dead end. So here's a helpful way to think about prevention. Metabolic disease develops when the friction to unhealthy choices is low and the friction to healthy choices is high. Prevention flips that equation. It means making nutritious foods more accessible than ultra-processed food, making movement part of daily life, not a separate task, supporting sleep, not glorifying exhaustion, and embedding health into communities, not isolating it in clinics. When this friction shifts, behavior follows. So if you take one thing away from this episode, let it be this. Metabolic disease is common, not because people are broken, but because our systems are misaligned with human biology. And the encouraging news is that early intervention works, community-based prevention works, and lifestyle change doesn't need to be extreme to be effective. When we intervene early, before beta cell failure, before vascular damage, before neuropathy and kidney disease, we change trajectories. And that's how we get fewer emergency department visits, fewer complications, and more good decades of life. Let's land this episode, team. If you take nothing else from this episode, let it be this. Metabolic syndrome and type 2 diabetes aren't mysterious. They're not inevitable. And they're definitely not fixed by one magic diet, one supplement, or one influencer's origin story. They're the predictable result of biology interacting with an environment that makes it really easy to be metabolically unhealthy. And here's how I want you to think about this in our 2-tier blueprint. Tier 1, prevention. The foundation, the stuff that changes your trajectory. Tier 1 is prevention, and I want to be clear. Prevention is not weak. Prevention is not nice to have. Prevention is the highest yield intervention in metabolic health. Back to our analogy, Tier 1 is about keeping the warehouse from overflowing in the first place, keeping the shelves open, keeping insulin working, keeping visceral fat and inflammation from quietly accumulating. We talked about how food quality matters over diet camps. Not perfect, not puritanical, just consistently better decisions most of the time. Use movement that fits your life. You don't have to be training to be a world champion. Just get enough daily movement to keep your muscles metabolically active and insulin sensitive. Combine some cardiovascular training with the resistance training and go back and listen to that episode. Consider sleep and stress as metabolic inputs, not luxury items. They're genuine levers that change insulin resistance. Engage in community and systems because health isn't just personal, it's environmental, it's cultural, it's socioeconomic. And the evidence shows prevention works best where people actually live. If Tier 1 is working, what you should see over time is waist circumference stabilizing or improving, blood pressure improving, and better lipid patterns. You should also see improved insulin sensitivity and lower long-term risk of diabetes and cardiovascular disease. Tier 1 is how you avoid the emergency department story becoming your story. Now, Tier 2, treatment. They are powerful tools when the risk is high or disease is already established. This is where we use more intensive tools when metabolic syndrome is established, diabetes is diagnosed, or risk is high enough that waiting can be dangerous. Tier 2 includes structured lifestyle programs designed for the big changes you need to make with the support of experts. Medications like metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. Bariatric or metabolic surgery for selected patients. The goal here is aggressive risk reduction, blood pressure control, lipid lowering, kidney and cardiovascular protection. And here's the key. Tier 2 isn't failure. Tier 2 is what you do when the fire is already burning and we need more than a smoke alarm. But Tier 2 works best when Tier 1 is in place because lifestyle is the metabolic foundation that makes everything else more effective. So what do you do next? Here's the simple version. If you don't have metabolic disease yet, Tier 1 is your priority, prevention. If you have metabolic syndrome or diabetes, you still do Tier 1 because it's foundational, but Tier 2 becomes a necessary layer to add on. And it's really important that you work with your physician on this. And if you're not sure where you sit, that's your cue to get your markers checked. Your fasting glucose or HbA1c, your lipids, your blood pressure, and your waist circumference. If you want help translating all of this into action, I've put free resources up on my website. So head on over to drkois.com and you'll find simple checklists, practical guides, episode show notes, and tools you can actually use in real life. No hype, just the fundamentals. If this episode helped you, or if you know someone who needs to hear it, please like, subscribe, and hit that notification bell so you never miss a scrap of content. Doing all of this stuff genuinely helps the show reach the people who need it most, and it helps us push back against the noise with something better. Evidence, clarity, and compassion. All right, team, that's episode 6. Thanks so much for joining me today, and I'll see you at the next one.